We're very delighted this morning. We're going to have a discussion with colleagues from AfroCAB, EGPAF, PATA, as well as Unitaid, talking about pediatric HIV treatment and the new formulation of pediatric ALD. Just before we start this conversation, just a few background details so that you are up to speed on where this is coming from. So we are all part of the Global Accelerator for Pediatric Formulations initiative. That's a WHO network that was set up to really close the treatment gap in pediatric HIV, but also in other diseases. As part of this initiative, we have what we call the Pediatric HIV Task Team, which is basically looking at uptake of the optimal formulations for HIV treatment. We started that when pediatric DTG came in a few years back, 6 years ago, and 2 years ago we had the chance to start looking into a fixed dose combination for kids, which is really about equity. Adults have had this kind of fixed dose combinations for many, many years, but this is entirely new for pediatrics. And so today we're going to talk about the progress towards rolling out pediatric ALD. And we're going to have 5 moments. So there's going to be a few slides. I'm showing a few maps so that you have the picture in mind. And then we're going to have conversations with our colleagues from AfroCAB, PATA, EGPAF, and we will have a closing from Unitaid. So these products, pediatric DTG and pediatric ALD, are made in generic versions. This has been enabled through a voluntary license that has been signed between MPP and pHIV Healthcare 12 years ago, actually, and the products have started being rolled out in 2020 and 2024 for pediatric ALD. The territory that is available for these generic formulations is shown here on the map. We have more than 130 countries who can access affordable, quality, and optimal HIV treatment for children. This is the map of supplies of pediatric DTG, the single pill. So this has reached 106 countries. So of course, I mentioned 130 countries that could access. So there's still a few countries who haven't had access to these products. But still 106 countries is quite a big achievement in a very short period of time. But now we have this fixed dose combination and we're doing the transition. We're far from 106 countries, but of course we've already had supplies that are in majority for this formulation. So the progress has been advancing well, but there's a lot of countries remaining, especially countries which have less children living with HIV. And we want to make sure that these also benefit from the best formulations. So just a few last comments. Last year, we saw really the uptake of pediatric ALD take off, so a lot of transition took place. The most used pediatric HIV treatment right now is already pediatric ALD, so that's good news, but there's many countries that remain. What we have right now are 14 countries where filings have taken place for regulatory approval. We have 21 countries with approval. Others are being supplied through waivers, like through the Global Fund. And then we have the 47 countries who haven't had access. So, this is all for slides. We will have now just a conversation, and the idea is really to try to identify what have been the good things about the transition, the opportunities, the learnings, and also the remaining challenges. So we'll start with my colleague from AfroCAB, Bahati, asking her if she can provide a community perspective on the transition and what makes caregivers and children really interested in this new formulation.
Good morning, everyone, and I hope you can hear me. So, as introduced, my name is Bahati, and I come from the United Republic of Tanzania, which is one of the countries where we have made progressive advancement, not only in transitioning, but actually having pALD available in our facilities starting this year, January. So, I think the work with community actually started last year in my country, where we were able to have conversation and follow up with our Ministry of Health, particularly the National AIDS Control Program, where we were like, okay, we've had this better drug for kids, what are the plans in the countries? And then civil society and communities were able to be part and parcel of the planning process. So we started with an implementation plan in our country where we started to enroll different levels of involvement, from the government to the facilities to the medical stores department. And we had our first shipments in my country last year in November and December. And starting January this year, we've now had them supplied across different facilities all over the country. And now I know the government is just monitoring the, what do they call it, the pharmacovigilance of pALD. But we are at a good stage where we are now getting feedback from caregivers, from mothers and parents on how this transition has been. And of course, as with any change, there's good acceptability, but there's also a few concerns with regards to any changes. So I think one of the most positive impacts we have had so far in feedback is because it's now easier to administer the drug compared with what they had prior. Because you know, previously it was either they had to use a syringe or they had to use separate two drugs, which were actually difficult for parents. So sometimes you'd find a parent giving the child two drugs but of the same bottle just because of that confusion. But now with a single drug, it's much easier to actually mix it with water or juice and give it to a child. And we understand how pALD has a better taste compared to the previous drugs who were there. So the uptake has been very much easier with the parents and caregivers, but also there is now a lower risk of administration mistakes, because you had parents now having to monitor two drugs, two bottles, but now with a single drug it's much more easier for parents to remember and administer. And of course, as I said, the beta test has been easier, but currently now we are almost 6 months over. We are hearing even better or rapid virus suppression among babies who were struggling for years to suppress their virus, but now we are hearing great results over since the transition in January. But of course, there are still some concerns out there with people who already use. Remember how parents were already trained before to how to take care with the previous drugs. So now you are telling them now you have to change to this new drug, and with any change there are still concerns, because there are some parents or caregivers who their babies were already undetectable with the previous drugs. Their kids were already used to the schedules of the previous drugs, and now you are telling them we have to be trained and make the babies used again to this new formulation. So that change could be a bit daunting to any parent as such. And of course, you hear some parents saying, oh, with this new drug, particularly with the bacavir, there are some concerns of allergy and reaction for babies. So with regards to any change, and now, you know, there's this perception also, if you combine everything in a single drug, some may say, one, it's easier, maybe the side effects will be more greater to a child, but also maybe also the effect of the drug won't be as strong as having two drugs. So those are everyday conversations that caregivers and parents had, but this is where we are instilling with the government that the retraining of the clinicians and the nurses has to go hand in hand with the supply side, because imagine a parent and a caregiver going to the facility and meeting a nurse or a doctor who has not yet been trained on pALD. So they'll have all these questions which won't be answered, and at the same time we are telling them when you go to the facility, demand for this better drug, you see, but then when you go, the drug is there but the answers are not as sufficient or efficient. So it's a two-hand power. We are glad we have plans in place, and we are hoping by the time at least this first year we'll have better answers to what this would look like. But the progress has been better than the negative side, and of course not all babies are the same, but we are hoping at least by the end of 2027 as a country we'll have data which shows more efficacy and acceptability of pALD compared to the separate doses that we had prior.
Thanks very much, Bharati. I think we heard that there's really a beneficial impact of transitioning to a fixed dose combination. I think it's going to be important to document that, and also to explain it to the communities and caregivers so that they know what is happening and why it's beneficial for them. So we'll go to the second panelist, Marta from EGPAF, who has been working through a few transitions and introduction of new products, and maybe can tell us a bit more about the challenges, but also the enablers of such transitions.
Hi everyone. Thank you for giving me this opportunity. As you have said, I'm Martha Mukaminega. I'm a pediatrician and I work for EGPAF, Elizabeth Grazer Pediatric AIDS Foundation. So that's a great question. So if I look at the transitions, and when I say we, a number of countries we have been working with. When I look at what we have been going through in terms of introduction, but also transition, I would say the main challenge is really to come up with a transition plan for each country. So what do I mean by a transition plan? You know, it is true that with pALD, one might think that it's a product, it's a number of products, but those products were known. But it required to update the guidelines because as a country, they need to have the pALD in the guidelines. So each country had a particular way to go about it. Some had to go through the technical working group. The technical working group means that you call the technical working group, you coordinate with other activities, and then you come up with, an updated guidelines. Some country also opted for a communication from the Ministry of Health, and then that communication was directed to regions and provinces and districts up to the facility level. Without that communication, then the pALD could not be introduced. I'm also with the plans. I'm also looking at the supply chain and quantification. What do I mean? So countries had also to make sure that they have the right quantity of pALD, and also to make sure that the medication that was already there is not wasted. And also to make sure that not only you have the pALD, but also you have standalone molecules that was going to be needed for some of the combination. The plan also had a reflection on how each country wanted to go about it. Was the country going to go for a phased approach, whereby maybe new initiated were going to start and then follow the appointment? So also that needed a discussion so that really the transition or the introduction is done in a proper way. With all of that, or even before, people had to be together. The community, the health workers, all the partners, stakeholders, to make sure that they get at a good understanding, the same understanding, so that the implementation could be done properly. So those are the not challenges, but areas that needed the attention of each country before going for the implementation of the pALD. Thank you.
Thanks very much, Martha. I think we heard a few things. There's a lot of background work that is taking place that might not be visible to caregivers and communities. It might not be visible for us at the global level. So thanks for outlining that. And also I think we heard about the risk of stockouts and the risk of wastage, and that when you have a transition, especially in a tight financial context, you want to make sure you don't waste any resources, but also you want to make sure that when you transition the kids, that you don't revert because the new drug is not there in sufficient quantity. So thanks for this. So maybe now we'll turn to Luan from PATA. We'll ask if there's any other insights from the facility level that you might want to highlight, but also talk about the caregivers and how they can be enablers of such transitions.
Thanks very much. I'm probably going to touch on a few things Martha also touched on. But just in terms of chatting to some of the health providers in the PATA network, I think some of the themes, I'm going to just try and highlight some of the themes raised. I mean, the one thing that really stood out was, everyone agreed that a smooth transition happens long before, the first child is going to receive a new formulation. So even at an actual clinic level, so your sort of lowest point of service delivery, substantial planning is needed. So not only the quantification, knowing the eligibility number of children that are going to require the new formulation, and then obviously ensuring that that supply chain is well in place. I think the one thing from a health provider perspective, we know the one thing that really undermines the confidence of a health provider is to start with a new formulation and then have to interrupt it and return back to our old regimen because there's been a stockout or a delay. So I think that's really something important to think about. And also just all of the, as Martha was saying, the guidelines being in place. But for health providers, you know, guidelines and big long documents are really not that helpful. So we need really simple charts, algorithms, dosage charts, things that really make it simple to be able to demonstrate very clearly at the point of care in terms of how new formulations are going to be managed. Many people also provided, I think helpful ways that, you know, governments made choices in terms of staggering transition, not doing it sort of all at once. Facilities being really, you know, critical in sort of making appointments, getting organized and managing that transition in a more sort of organized manner. So they could actually look at their own case reviews, identify the children that needed to be transitioned first, and make appointments. So I think that was really helpful. I just wanted to pick up on some other things around, I mean, obviously the confidence of health providers. I think often we just underestimate that, you know, you can give a health provider a pamphlet or explanation. But health providers are really, they have to deliver this message. They have to motivate a caregiver. And as Bahati has said, many caregivers, you know, they have a bit of fatigue. This is the second or third time they've had to transition. And it's like, why again? And I think that point of, especially when my child's already virally suppressed. So health providers need to be so confident on why. We need to help them to answer the question why. Why is this going to be better? How is it going to be more convenient? What is in this drugs that's different to the previous drugs? So I think really being a lot more practical in our training, having point of care training, peer-to-peer learning, and I think the value as well at a site level is really being able to monitor adverse events and to really talk to frontline health providers around how is this transition really working, what's working well, what's not working well. A lot of these things we often leave as an afterthought. And then just the relationship with the caregiver is fundamental. So I think we often, you know, we often talk about the community and the clinic being quite separate. But your health provider is really powerful in terms of being able to equip a caregiver, give the caregiver the confidence, really demonstrate, show, don't just say how to do it. You know, we take the tablet, we put it in the water, we demonstrate how it needs to be done. And to be motivating, and to be a role model. And I think also the health providers don't just sit in the clinic. I mean, there are ways that they engage in the clinic committees. There's a way in terms of engaging with the community. So when we prepare for transition, it's not just the health provider in the clinic, but even broader in terms of the community. And really engaging with the clinic community structures in terms of that kind of feedback. How's it working? What's happening? To really have a open dialogue. And I think importantly for health providers then to be able to listen to that and to make improvements in terms of how they're doing things. And then the power of a peer-to-peer, you know, between facilities, you know, how health providers come together, problem solve, help each other, where one, you know, learns something. And really using that, I think, networks of health providers together to problem solve together. Thanks.
Thanks very much, Luan. I think you read my mind. There's two questions I want to ask, but before I'd just like to say, if you have any questions, it's the right moment to think about those, because after this next round, we're going to go to the audience. Maybe one question, a bit of script, but that you hinted to. We're in Latin America. We've seen only a few countries make the transition. We've seen and heard about some countries pushing back on the transition, saying that, you know, these are the same drugs, and that, you know, this may be overcomplicating doing another transition. So my first question, I'll have two, and then I'll let anybody answer. First question is, how are your networks, your organizations also reaching out to countries where you may not have a footprint, but where your experience might be very useful. And the second one is about the tight context in which we are. And if you see what you see about transition, that can be a benefit in terms of the timing, in the sense of saving resources, being more efficient, but also a transition being a very sensitive moment where a crisis could derail the process. So it's open to anybody to answer.
Yeah, that's a good question. It's a good question. So if I use an example as EGPAF through a technical assistant project, EGPAF is supporting the rollout, the introduction of pALD in countries where EGPAF does not have a presence. And some of those countries actually are in Latin America. And also in Africa, but in countries where EGPAF does not have a presence. So how do we go about it? So based on the experience from the countries we have been supporting, we have learned a few things. So start with the government. Start with the government. Start with the community. Start with the stakeholders, partners who really are influential, because it is true, pALD has those three molecules. They are known, they are already in country, and now I'm putting on a pediatrician hat. That child who has been taking two different pills, if that child is given an opportunity to take one, that will really be very beneficial from the caregiver, from, as Juan was saying, from the provider, because they will be able to tell the caregiver that, yeah, this is what you are gaining from two drugs to one. And it's not only that benefit, but that's really something that has convinced some of the countries. But now, looking at the funding environment, that is important. It is great to also keep in mind that because you have gone through other transitions, there are lessons we have learned. So there is no way the transition, the introduction of a new product will be smoothly done if the coordination is not done. Now, we have learned that, yes, a face-to-face discussion is important, but based on the current funding environment, we have also learned that some of those things can be done online, remotely. It is not always ideal, but it can make things move in this context of limited funding. So I can give other examples through that experience, but maybe let me stop here for now.
I mean, I'll add just something really, I mean, I come from South Africa, which sadly is one of the countries that hasn't quite got to rolling out. I mean, I think we're making good progress, but actually many countries are ahead of us. But one of the things, I mean, I know in South Africa, for example, you know, pediatric DTG had only really been introduced, 2 years ago. So I think some of it's just timing, and we're having to like live through that kind of process. But I mean, absolutely, I think there's a real big need for advocacy. And advocacy for a focus on children's medication. Because quite frankly, in many countries, that's not going to be prioritized. So I think a lot of our work, you know, I work in a network of frontline health providers, and I think health providers themselves saying we want simpler, you know, formulations, we want things to be more convenient, we want children to have the best outcomes. You know, health providers need to be saying that loudly and proudly, but we also need to work with community and networks. And networks who sit in powerful positions, working with government, to really advocate specifically for children, because I think we're quite good in those structures, talking about other populations, key populations and other groups, but often really neglecting the benefits for children. Yeah.
1 minute also. I think what Luan also was saying with regards to advocacy, I think also that's where best communities sit at. And it's the benefit of what's best for the child. You see, in a lot of our countries, we are not doing well with numbers for babies and pediatrics, whether it's viral suppression or mortality. So if there's something that could cause better adherence, but also better viral suppression and save their lives, why not? So this is where, as advocates and community work across different subcommittees, different technical working groups, and pushing demand and want. And I think the work of the government is not to say, okay, we're going through many transitions, but what's best for the children, and this comes from the caregiver themselves and the parents of these kids who want something better for their babies. So I think it's that convincing and that advocacy that needs to be consistent, and that's where best we are all placed to support and push one another.
Okay, thanks very much. So we'll open to the floor now. Just a reminder, we have Bahati from AfroCAB, Luan from PATA, Martha from EGPAF, and we also have Jess from Unitaid, the founder. So if there's any question, that's the right moment to ask.
Thank you very much. I'm Chomkama Flavia from the National Forum of People Living with HIV Networks in Uganda, and I think this is the way to go. I'm not asking a question, rather confirming that in Uganda we have seen the transition, but the transition is least known to the communities, because at first we even thought there was a stock out until we had to engage the ministry to find out what's happening. Why aren't we children having drugs? Until we were informed that there is going to be a transition and there are new medications being introduced. So we believe that if we are going to have new medication, for instance, we have networks of people with HIV in all countries, we need to make sure they know, and we are able to allay fears of communities, and also to avoid the thinking that they are stockouts, when indeed there is a shift in the available and much better medication. And truth be told, if my child is already immune suppressed, I would not quickly move to another drug regimen. I would be asking questions. So those are the things that we need to clarify. If new drugs are coming, we need to know the why, and why now, and what is the difference between the old and the new, because mothers, we have already been used to administering what we have, and so these changes sometimes disrupt and also affect the way mothers respond to the new regimen, even when they are known to be better. So we would like to engage with partners, particularly government, and also to appreciate Unitaid and partners like AfroCAB for allowing for new formulations to come. And we believe that improve the response and reduce the resistance that might be happening where children are not suppressing. We thank you.
Thanks very much. I think you raised a very important point. If you want caregivers to be allies, they have to understand and be part of the solution. Are there any other questions from the crowd? Otherwise, I can also ask our panelists if they have questions for each other or for the audience as well.
Yes, I think mine could go, I think mostly for Pata. So with the pALD, I think something that also has a bit of question from my country is, you know how it comes with different bands with the weight. So from 6 to 19, but for instance in my country, we have 3 band weights with 3, 4, 5 pills per day, which that sometimes is very daunting for a parent or a caregiver, where if my child was 6 kilograms, I was given 3 pills, and now my child has continued to 11 or 12, and I have to take 4 pills. I think these are the questions which I'll ask Pata, but also maybe Jessica, if there's plans to make it more easier in the future along the way.
I'll take the hard question. I think we always need to keep the children in mind, and we always need to make better options available. I think we should remember where we came from. Local retail was horrid. I mean, that was a syrup with 40% alcohol. It tasted awful. When I first started in public health many moons ago in Lesotho, and I was shocked to see how
we had to, divide the tablets for the D4T, and then everything was separate, and then on top of that, the drugs themselves were awful. We decided
Yeah, thank you for the session and discussion. So I think for some of us, what really concerns us is, I know the goal of GAPF is to try and shrink that timeline to access, but the reality is that that timeline is always fraught with challenges. Just to give you an example, I remember when pediatric dolutegravir came out. We had countries resisting to move children from a lopinavir-based regimen to a dolutegravir-based regimen. And they had some of the most ridiculous excuses, such as they had a huge stock of lopinavir. 2 days earlier, they were talking about how challenging it's been to achieve viral suppression in children, but still feel that they have to keep children on that treatment for a lot longer period. And yet when it comes to adults, we can make noise and say, again, another example, when we were transitioning from D4T to TDF-based regimen, we demanded it's done immediately. So I'm just thinking, how does the panel feel we could best support children to ensure that they are on the best optimized regimens as soon as they are available?
maybe I can start. I can tell you what we did last year when we saw that there were major cuts coming from the U.S. government, and pretty much every where we worked was impacted, and every country more broadly. I mean, it wasn't just where Unitaid was funded, but everybody was massively impacted. And so within the context of some of our grants in sub-Saharan Africa, we added some extra support so that specifically one of the points was that for support to transition from pALD, because we knew that the U.S. government was largely funding that, and we didn't want to see it fall through the cracks. And so we wanted to enable, TRI, AfroCAB, and the other groups to be able to make that a priority, so that the kids didn't again, fall through the cracks. So I think it's a concern. It's going to be more and more of a concern, and we're slowly, with all these questions, eating into my copy points that I had for later. But I am quite worried about the funding cuts and the transitions that we're going to see. Transitions to domestic finances, transitions from U.S. government procurement and global fund. And I think we do need to make sure we keep pediatrics top of mind, making sure those drugs are getting to the clinic and the kids that need them. Now let somebody else have a turn to chat.
It will always go through advocacy to the Ministry of Health, so that really children are prioritized. It goes also through discussion with the partners. We have seen in some of the, and I can name Global Fund, we have seen some of the area being highlighted and Global Fund telling countries to make sure that this component is included in the funding request. We would love to see Global Fund and others making sure that children are included in each and every opportunity that is available at country level. So really tapping at different levels, government, donors, so that they can really prioritize children. Thank you.
I mean, maybe just part of what Martha's saying. I mean, I think people, I mean, I feel like now I'm saying people will remember, so it's something in the past, and this shouldn't be in the past, it's still with us. But we had a global alliance to end AIDS in children, which was a strong partnership between WHO, UNAIDS, and other partners, including GMP, YPLUS. And all of the countries signed a declaration and actually developed a very clear, strategic, child-focused plan. And the reality, since the funding cuts and impacts at a global sort of level in terms of those structural arrangements, we've really seen that, I don't want to say disappear, because to be quite honest, we have very few or none platforms that really strongly advocate for children. So we have many other networks. I mean, we are co-chair of the Coalition for Children Affected by AIDS, and we were part of the sort of steering committee of the Global Alliance to End AIDS. But to even keep those structures going seems really, really difficult. And I do wonder, how can that be? I mean, and how we shouldn't allow those structures to disappear. And particularly because countries did sign a declaration, how can we still hold them to account? But of course, they required support. They were all asking for technical support. Of that. So I think it is something to think about in terms of investments in structures, and even those structures then sort of disappear.
I guess you didn't talk just when they asked that. I think just to highlight what you said, I think in the past we did very great work to push access faster to other products. For instance, when we were pushing for DTG for women, we convened women in Africa, we helped them what they want, we wrote statement paper, we sent to our ministers, we sent to WHO, to the African Union. So maybe the question, what is stopping us right now to do also the hard work with children? I think the sad part is the children are the afterthought, but also we need very strong advocacy in countries. So we need people who know the systems, the supply chain, who to call. As we want to say, even with the Global Alliance, at times, of course, we do need money, but having passionate community people who can pick up the phone and call their member of parliament, to call the member of Ministry of Health and ask, where are the pALD? We have this, where are we as a country? I think that also works and push very well, so we can all push for various efforts to ensure change in our countries.
Thanks for these very interesting comments. I want to add maybe two things. In some countries that haven't transitioned, as many of these countries have very little numbers of kids, and so it's never going to be a priority for them. It's never going to be a topic that a person in Geneva working for the government will know about, because this is a niche issue for them. So we need to make sure that we share that information with clinicians, with communities on the ground, so that they can advocate with the right person. And maybe one thought that has really stuck with me since a year and a half, when there was a convening by the Vatican on pediatric HIV, and Chip Lyons was saying, that the former head of EGPAF was saying, nobody's against children, nobody ever excludes children, but this is not enough. We proactively do something. We need to put them at the top of the agenda. Otherwise, everyone will go by the majority, and there's more adults living with HIV than children, so there will always be less. So we need to prioritize them. So I think now we're almost at the end of our time. Maybe if there's any burning question, otherwise we'll move to the closing. Any question? No? Okay, all right. So over to you, Jess, for some closing thoughts.
Great, thanks.
worried about children being lost. But now with integration and the numbers being smaller and healthcare providers expected to integrate and understand all the 10 million guidelines that speak to different conditions, how can we make sure that children with HIV are safeguarded within all of that integrated process?
We have the two tough questions for the end. And I'm going to already say that I'm not sure if I have the answers. I mean, I think everybody got such a surprise last year with the funding cuts, and it made things quite difficult. But I think we've been impressed and surprised by the resilience, and that countries are stepping up. Countries are trying to get things back together. There were countries where they didn't even have access to their data systems for a little while. So I think at least things are going in the right direction, but we need to not lose sight of it. We need to make sure that we're enabling the communities. I think the communities are always the most important advocates. They're the most important, that we should all be consulting and making sure the systems are working for them, and that they're the ones who are being counted. So I think it's a global solution in that we're all partners in this, and we all need to make sure we keep raising the issue. But I think it's going to be quite difficult for the short term. But I think we know what we're capable of. We know what communities did before. Before we had all of these different systems in the past, communities came together and they were able to advocate for themselves in each country. And so we need to really strengthen that and support and keep this piece going forward. So I think that's really the most important part of the solution. So I don't have all the answers, but I think we just need to keep talking about it. It's also quite important that we don't get lost in trying to have headlines that things are going in the right direction if they're not. We need to be honest, and we need to really keep talking about it.
Yeah, so we'll be available, I think some of us at least, for questions or discussions past that. I just want to thank everyone for taking the time for this discussion. I think it's very useful. Thanks AfroCAB, pALD, EGPAF, and also thanks Unitaid. Unitaid is also our funder for HIV work and our founder 16 years ago. So thanks very much, everyone. We'll take a picture and then we'll be available for discussion. Thanks very much.